Next, let's take a look at extrapulmonary tuberculosis. In 10% to 40% of TB patients, they may have extrapulmonary tuberculosis. 2/3 of HIV-infected patients may have both pulmonary and extrapulmonary tuberculosis, or extrapulmonary tuberculosis alone. We have several different types of extrapulmonary tuberculosis: lymph nodes involvement, pleural involvement, peritoneum involvement, pericardial involvement, and even meningitis of tuberculosis. And genital urinary tract can also be involved by tuberculosis. We can also have bones and joints tuberculosis. We are not going to talk about everything. Mostly, we're going to take a look at lymph nodes and pleural involvement. For lymph nodes tuberculosis, it is also called tuberculosis lymphadenitis. They are the most common extrapulmonary tuberculosis, are very common in HIV-infected patients and children. This is a picture of lymph node tuberculosis in this child's neck. You can see the lymph node tuberculosis actually ruptured to the skin and formed a fistula. For lymph node tuberculosis, usually they are painless swelling and non-tender mass. Most commonly happen in posterior cervical and supraclavicular sites. They can be discrete or they can be matted. They can form fistulous tract, which can drain the casing material in lymph node of tuberculosis. To diagnose lymph node tuberculosis, we use fine needle aspiration biopsy or surgical excision biopsy. Of course, we need to do the differentiations for lymph node tuberculosis. They need to differentiate it from lymphomas, metastatic carcinomas, Kikuchi disease, Kimura's disease, and Castleman's disease. For pleural tuberculosis, they account for up to 20% of extrapulmonary cases. The nature of pleural tuberculosis is a hypersensitivity response to mycobacterial antigen. They can happen because of contiguous parenchymal spread. The fluid can be small or large. Some may even be unnoticed and resolve spontaneously, but some may cause symptoms. On physical examination, usually we can find dullness to percussion or absence of breath sounds. This chest X-ray shows large amount of pleural effusion on the right side of this patient's thorax. And this CT scan shows capsulated fluid in patient's right side thorax, and you can also see the thickening of patient's pleura. To diagnose pleural tuberculosis, we do the so-called thoracentesis to drain the pleura or effusion. Usually the pleural effusion of tuberculosis is straw-colored. Some of them may be hemorrhagic. The property of pleural effusion is oxidative. They may have normal to low glucose concentration. The pH value is usually less than 7.3. We can find neutrophil, and we can also find lymphocyte predominance in pleural effusion of pleural tuberculosis. Acid-fast bacilli are rarely seen in pleural effusion of tuberculosis, but we can find increased level of adenosine deaminase. And also we can find lysozyme and interferon gamma in pleural effusion of pleural tuberculosis. Needle biopsy of pleura may help us do the diagnosis of pleural tuberculosis. Miliary or disseminated tuberculosis is also an important type of tuberculosis. They are actually hematogenous spread of tubercle bacilli. We can find yellowish granulomas that is 1 to 2 millimeter in diameter on the section of patients' biopsy of lungs. Patients with miliary or disseminated tuberculosis usually have non-specific or protein manifestations. Predominant site of involvement is patient's lung. Patient may have fever, night sweats, anorexia, weakness, and weight loss, just like other types of tuberculosis. Physical examination of miliary tuberculosis may find hepatomegaly, splenomegaly, and lymphadenopathy. Choroidal tubercle by eye examination can be found in 30% of patients. Fewer than 10% of patients may have meningitis of TB. Miliary tuberculosis patients have specific chest X-ray appearance. They are called miliary reticular nodular pattern. But at the early course or in HIV-infected patients, chest X-ray may find nothing. Some of patients with miliary tuberculosis may have large infiltrates in their lungs. Some may have interstitial infiltrates also, especially in HIV-infected patients. Pleural effusion is not very common in this type of infection. This is the chest X-ray of patients with miliary tuberculosis. We can clearly see the evenly distributed small nodules throughout the patient's lungs. The CT scan shows miliary nodules throughout the patient's lung. Another patient of miliary tuberculosis. Thank you for your attention and patience.